Imaging modalities can be used to diagnose the infective endocarditis or confirm the infective endocarditis. Like as I told you, this is the first image is a 2D echo showing a vegetation on the mitral valve leaflet. The video I showed you is like aortic valve vegetation, and this is a mitral valve vegetation. And again, this is a MRI image showing vegetation on the mitral valve, and this is a PET scanning showing the root abscess or mitral valve, the aortic root abscess in the image C. So various imaging modalities can be used to confirm the diagnosis or to plan the surgical treatment. Depends on the presentation of the patient and also the timing for surgery. So, on complications, this patient can have various complications like congestive heart failure, which is the most common presentation in acute infective endocarditis patients. Because of the acute MR or acute valvular regurgitation lesions, the patient will have a congestive heart failure symptoms, and the main indication for surgery in this congestive heart failure presentation is also one of the important emergency surgical indication in almost 60% of these patients. And some patients can have uncontrolled infection, like persisting infection in spite of 6 weeks or 4 weeks of antibiotic therapy. And some people will have a perivalvular extension in case of a root abscess or fistulas causing various communication between the chambers of the heart. So making the treatment plan very difficult. And some people will have a systemic embolization into the brain, spleen, kidneys, lungs, having colonization of the organisms in that particular area and causing abscesses in 30% of the patients. And sometimes they can this can be the first presentation also, as I told you, like in subacute cases especially. So the main model of treatment includes either antimicrobial therapy and surgical therapy. Some patients, especially the right-sided heart failure, right-sided infective endocarditis patients, usually they get treated well with antimicrobial therapy alone, and sometimes the vegetations also can disappear or they heal. And in rare conditions, they might require surgery. And most of these left-sided lesions, left-sided means aortic valve or mitral valve infective endocarditis patients. Usually, we plan a course of antimicrobial therapy followed by surgical therapy. In some people where antimicrobial therapy is not responding or any acute conditions, as I mentioned earlier, we might have to do emergency surgeries and do a source control. Then only we can be able to this antimicrobial therapy will respond. So there is various usual antimicrobial therapy for this common causes of the infected endocarditis patients. Usually it includes a 2 weeks to 6 weeks antimicrobial regimen, depends on the organism, which is commonly see. So for a streptococcus, usually for Staphylococcus aureus and all these things, we might we usually give one week of aggressive antibiotic therapy followed by immediate surgery, and then followed by 4 to 6 weeks of again antimicrobial therapy. In those patients with the subacute cases or chronic cases, we usually give a 6 weeks complete course of antimicrobial therapy and monitor the patient for not having any septic emboli or embolic symptoms. If the patient is having any complications or embolic symptoms, definitely it is an immediate surgical indication, and we proceed with surgery and then do a source control and followed by again continuation of the antibiotics. Otherwise, usually this is a usual antibiotic therapy what we give. It includes a penicillin G or ceftriaxone. Nowadays, penicillin G availability is a little bit difficult, so most of the patients we give ceftriaxone and gentamicin, or ceftriaxone and vancomycin in some patients with resistant organisms. And surgical therapy, the main indication includes congestive heart failure, the patient presenting in acute condition with a congestive heart failure, severe acute MR or severe acute AR. We have to take them for a surgical therapy, and then we have to do valve replacement surgeries along with the debridement of the vegetations or infective lesions, and any perivalvular invasive lesions like a root abscess or fistulas basically. So ventricular fistulas or root abscesses causing more destructive pathology, which is one of the indication for surgical therapy. And then uncontrolled infection despite maximal antimicrobial therapy. Some organisms are very virulent or the non-responders will be there, or the bacterial load is very high. In those patients, usually they don't respond very well for this antimicrobial therapy. So sometimes we may have to intervene, and then we have to do the source control, then followed by continuation of the antimicrobial therapy. And presence of the prostatic valve endocarditis again is one of the main indication, because once the prostatic valve is infected, then there's no point in keeping the valve there. So we have to replace the prostatic valve with a new prostatic valve, which includes a tissue valve. And large vegetation, that is more than 1 centimeter to 1.5 centimeter, which carries very high risk of embolization, systemic embolization. So that needs to be taken out. So it's one of the important indication for a surgical therapy. And patient is having a major emboli. Any patient who is having an infective endocarditis diagnosis or symptoms of or vegetations on the leaflet with any embolic episodes, we have to intervene and then the source control, then followed by antimicrobial therapy. And patient presenting with heart blocks, new onset heart block or new onset murmur. So these heart block patients, it means that the patient is started having perivalvular invasive disease involving the conduction system of the heart. So we have to intervene and do a source control. So the mortality depends upon the virulence of the organisms and presence of complications at the time of presentation or at the time of intervening for a surgical or microbial therapy, and pre-existing condition of the patient, and development of the perivalvular microbial abscesses, myocardial abscess, and use of combined antimicrobial and surgical therapy. So this is just a various percentage of mortality in various studies. So in these patients, usually Staphylococcus aureus carries a very high mortality of 25 to 47%, followed by fungal and enterobacterial group of organisms. And most commonly, the Staphylococcus viridans, they have a milder course and with a less mortality of 4 to 10% or 4 to 16%. So the prevention. So antimicrobial prophylaxis is very, very important for those who are high-risk patients when bacterium-inducing procedures are performed, like any dental procedures or any procedures involving catheterization or cystoscopy or any endoscopy or any procedures which involves bacteremia, a possibility of bacterium, we should always give a proper antimicrobial prophylaxis, and then we should plan our process. And we can also see some guidelines in these websites like American Heart Association, the British Society for Antimicrobial Chemotherapy. Thank you.